Hello and welcome to this afternoon session of GLOW 2020. My name is Tista Day and I'm an obstetrician and global maternal health PhD student at the University of Liverpool. And I have my colleague here today.
Hello everyone, my name's Helen Allett and I'm an obstetrician as well, and I work here in the Liverpool School of Tropical Medicine.
And today we're going to be your chairs for this afternoon session of GLOW 2020. Thank you all so much for joining from over 69 countries globally for GLOW 2020. We've had some fantastic presentations from enthusiastic, passionate and inspiring specialists in global maternal and newborn health. And this afternoon is no different, as I'm delighted to be able to introduce the fantastic Professor Wendy Graham to join us today. Wendy is a professor of obstetric epidemiology at the London School of Hygiene and Tropical Medicine. She holds a wide array of prestigious senior positions in academia and has been a technical advisor to both the government and several UN agencies. She's also a passionate advocate for the improvement of maternal and perinatal care outcomes, particularly in low and middle income countries. And she's also one of the founding members of the GLOW National Steering Committee. And so without further ado, it gives me great pleasure to be able to welcome Wendy to chair our first session this afternoon on respectful care in the age of COVID. Welcome, Wendy.
Thank you very much indeed, and good afternoon, good morning, good evening for those of you around the world who are joining us. This session, which is looking very specifically at this unusual context that we're in, COVID-19, and the implications for mothers, newborns, and for healthcare workers. So Tista has already introduced me. I don't need to say any more. The important work will be done by my colleagues, the panelists that are joining us this afternoon. And none of us are in the same place. I'm in Edinburgh, in Scotland, and then we have people not even in the same city. So we have countries represented from Netherlands, Tanzania, Uganda, and the United Kingdom. So we are very dependent on the technology, and I hope it works for us. The world, I think, is upside down at the moment. I think that's a simple description of the way things are. When we first started planning GLOW 2020 over less than a year ago, none of us could have imagined that we were going to have to move the conference to online, nor indeed were we having to allow some space within the conference program to talk about a global pandemic. But as I reflect across the last 2 days, and indeed the talks today, I think the MNH research community has been extraordinary in the way that we have responded to help shine a light on what is going on for mothers and newborns. Many people have changed their research program, adapted their projects to enable us to see and, as I said, shine this light. And all of the talks which have mentioned COVID-19 so far make it clear that we have a massive amount of disruption to services right the way across the world, disruption to services and to people's lives, to women, to children, to their families, to newborns and to healthcare workers. This disruption is in terms of their physical, mental and social well-being. We have to regard this as a challenge that has all those dimensions. And just last week, I was on an excellent webinar hosted by Lenka Benova, who's going to join us on this panel. And what really struck me was about the comments about the mental health and the challenge to mental health of healthcare workers at this time, mentioning that in many communities, the healthcare workers are both heroes and seen as vectors of the infection. So this issue for your mental health, imagine being seen as a hero, but also as someone bringing infection to your family and your community. You can imagine how that wears down one's mental well-being. So here we are now looking at this particular session of panel on respectful care in the context of COVID-19. And I suppose as I think of my sort of reading on the subject, and in fact my return to clinical care, I think the thing that strikes me the most, and it also was echoed by Professor Salome this morning, is respectful care is synonymous with quality care. We therefore have to think about respectful care, not just in terms of those who provide the care, but those who receive the care. And we have to think of quality care in all its dimensions. So here we have in many parts of the world some very basics that are missing. So no quality means no respect. Those things that are missing are very basic, like water and sanitation, and now PPE. And COVID-19 has really shone a light on this fact that we have basics that are missing. And so my big question that I hope to unpack in this session is, when we have so many basics missing, what can we really expect? What is possible in terms of true respectful care? So I'd like us to revisit this. We have this fantastic panel assembly that are going to take a global view of these issues around COVID and respectful care, and from looking at low and middle income settings. On the website for GLOW, we have fantastic bios of these wonderful panelists, and so I'm not going to say very much about them. So please do look and see what expertise we've got here this afternoon. The session will commence with 2 video presentations. We'll then have a panel discussion involving 4 questions, which I will direct to different members of the panel. We will then have some polling of the audience to make sure you're engaged. I know this is a postprandial period, but I'm sure you'll want to join us in the polling. So be prepared to use the app to poll, the app on the website, to poll your responses to some questions. And then if time permits, we will try to have a Q&A session. And if we fail, because time has run out, we've had such excitement in the panel, I do apologize in advance. Please post your questions still, and we'll try to answer those in the after the online version in the follow-up to today's session. So on that note, I'm hoping the technology is now going to whiz in. I'd like to introduce the first of the 2 presentations. The first one is going to be given by Dr. Aline Saman from American University of Beirut. Again, look at her wonderful bio on the website, and she's going to share findings from a global survey of providers. So the whizzy people with the technology, I believe you're now going to show the video. Please.
Hi, and thank you for joining this session. I am Aline Saman, and I will be sharing key findings from a global online survey of maternal and newborn healthcare providers during the COVID-19 pandemic. The study is led by Dr. Lenka Benova from the Institute of Tropical Medicine, and I'm presenting on behalf of an international team of colleagues and collaborators. First, a quick introduction to our study. It was conceptualized at the very beginning of the pandemic with the purpose of documenting the impact of the pandemic on healthcare workers' experiences and on the care provided to women and their babies. We wanted to follow up the situation over time, so we used repeated rounds of a cross-sectional online survey. We disseminated the survey to maternal and newborn healthcare workers by email and social media and through personal organizations. The survey went online on March 24th in English, Arabic, and French. We then added 10 more languages. Round 1 of data collection continued until early July, and the second round is ongoing. The questionnaire included 3 core modules that addressed preparedness and response to COVID-19 and healthcare providers' experiences and concerns. The 4th module was optional, and it focused on adaptations to care processes for both outpatients and inpatients. To briefly describe our sample from the first round, we received around 1,400 responses from healthcare providers in more than 100 countries. Most of them were from high-income countries and were females. Around 2/3 of them were midwives or obstetricians and worked in hospitals. Moving forward, we found that some measures were taken during the outbreak that potentially affected the provision of compassionate and evidence-based maternity care across the continuum. Starting with pregnancy period, these included interruptions to care and delays in routine antenatal visits. Facilities prioritized high-risk women for face-to-face visits. Even during these visits, providers tried not to be in close contact with women and avoided unnecessary touching, which may be stigmatizing to patients. For labor and childbirth, the use of some pain relief options like nitrous oxide stopped in the early phase of the pandemic in some countries like the UK. Facilities also decreased the number of birth companions and visitors allowed to either one or none at all, thus leaving women with less but much needed support during labor. Some facilities adapted staff rotation systems to reduce crowding. The rotation disrupts the continuity of care for women in labor. Out of fear, women were also reluctant to visit the health facilities and preferred other forms of care, such as home birth. their choices were not always respected, as the quote indicates. In the postnatal period, early discharge was encouraged and postnatal monitoring was delayed or shifted to phone calls. This means leaving new mothers, and I quote, to feel very left alone. Beyond immediate adaptations to care content, healthcare providers lacked the needed guidance as respectful care guidelines were not prioritized. Some interventions were ad hoc and did not align well with the available evidence, such as isolating COVID-19 mothers from their newborns. Second, there were reported shortages in skilled healthcare workers, either because they were reassigned to COVID wards, self-isolating, or unable to reach their workplace due to lockdowns. This increased the workload on those who were present at the facilities, leaving them with less time to spend with patients. Third, personal protective equipment can be considered as a double-edged sword in this case. Although they are much needed to protect the workers and the patients, they did make the patient-provider communication much harder and dehumanized the care. Also, putting them on takes time and can delay urgent action. In some African countries, women were asked to purchase their own masks before being attended by the medical staff. Finally, I would like to highlight that the carers, our respondents, worry deeply about not being able to provide compassionate care to their patients. Preliminary findings from round 2 of the survey show that 20% of them feel that they are not able to provide the same respectful care to women and newborns as they did before the outbreak. In the words of a midwife from the UK, "My heart just breaks for women and families who we won't be able to offer the full range of midwifery support to." Thank you for listening. For more information about our study, please see the paper published in BMJ Global Health and visit our study website.
Thank you very much, Aline. That was a really stellar presentation. I do apologise to the audience if the part of the slides are of the video was a bit blurry. You can watch the video obviously outside of this particular session. I encourage you to go back because this is a really extraordinary piece of work. And we are very lucky to have Aline do that presentation for us. We're going to discuss these presentations as part of the panel, so I'm going to move directly on to the second presentation, which is being given by Professor Jim Thornton, who's Professor of Obstetrics and Gynecology at Nottingham University. Again, do please read his stellar bio, which is on the website. He has the most interesting blog called Ripe Tomato, which I encourage you all to go and have a look at. And this will also be a video recording, but we will have Jim joining us on the panel this time. So over to the technology, and Jim will talk in particular about the evidence on COVID-19 and pregnancy, particularly the UK focus. So technology helpers, over to you.
Hello from Nottingham, the home of Robin Hood. I'm talking to you because I've been collecting all the primary sources on COVID-19 in pregnancy on my blog. The link is here, and on the next slide is the homepage of my blog. There's about 260 primary scientific papers about COVID-19 in pregnancy on there. To start, let us remind ourselves what the previous coronavirus did to pregnant women, SARS and MERS. They were extremely serious. Nearly 1/3 of women who were affected and 1/3 of babies who were affected died. COVID seemed initially to be less severe. The first report was a small series from the Lancet, 9 women and no mothers or babies died. But there were a number of reports that were a little bit alarming. There were deaths in the newspapers. There were also famous footballers' wives and all sorts of stories. And it was difficult to sort the whole thing out until later in March, early April, when the registries started reporting, and these are the most reliable data. The first 3 to report were Northern Italy, Lombardy, the home of what the centre of the epidemic there. They reported 77 women. Quite a lot of them had severe disease and one had ECMO, but none died, and the babies all survived. In the Netherlands, there was one woman who died. And in France, a much larger series, 600 women, 6 ECMO, so it's pretty severe illness, but again, only one died. I think the best of the registries is the UCOS one, where Marion Knight from Oxford collected all the cases from every obstetric unit in the UK. She ended up with 427 women, and she observed that the risk factors were much the same as outside pregnancy: ethnic minorities, overweight, and other problems. And she observed a 1% risk of the mothers dying, and out of 200 babies who were born, 7 died. That was the situation a few months ago, but last week the WHO Living Systematic Review came out in the BMJ from Shakila Thangaratnam, and that one showed 73 mothers who had died out of 11,000 pregnant women. Now, I calculate that as 0.6%, but actually, if you do the correct statistics, meta-analysis, she calculates it as 0.1%, so a bit lower than previous reports. I find it difficult to understand because the CDC from the US, which was the largest series, 8,000, had 0.2%. So I don't quite understand why it's only 0.1, but Shakila tells me that is correct. And if you look at the stillbirth rate, 6.3 per thousand, and neonatal deaths, 3.5 per thousand. So in conclusion, this is a serious condition, but it's not as severe as the previous coronaviruses, and the mortality rates are similar in pregnant women to non-pregnant women with the same risk factors. I've not given you the information about the risk from different birth routes, but there are other data suggesting that being born vaginally breastfed or allowed contact with the mother does not increase the risk of the baby being infected. Thank you.
Thank you very much indeed, Jim. And I think Jim is joining us by a Zoom link, so we won't actually be seeing Jim. But just to thank you, I know there was quite a lot of challenges in creating that video for us, but it's an excellent background to the rest of the panel conversation. So thank you, Jim, very much. I'd like to bring on board the panel. It's for me to introduce the rest of the panel, if that's possible, on the screen. Again, just to emphasize that the full bios of these wonderful individuals, Jim is with us by Zoom, so that's good, excellent. The full bios are on the website, but let me just run round. We have Professor Asma Khalil, Professor of Obstetrics and Maternal Fetal Medicine from St George's, the University of London, who can wave, I guess, just to be obvious. Then we have Professor Peter Waswa, who's the Professor of Health Policy Planning and Management at the School of Public Health, Makerere University. He's been heavily involved in a lot of the work on the Every Newborn Action Plan. Thanks, Peter. Then we have Dr. Beatrice Mweleki Makula, I must say that correctly, who's joining us from Muhimbili University, who's a nurse and a midwife and head of the community health nursing at the Muhimbili University. Thank you, Beatrice. We then have Jim Thornton, who I've already introduced from Ripe Tomato and the University of Nottingham. My video is working now. Yes, good. Glad to see you, Jim. And last but not least is Professor Lenka Bonova, the Professor of Reproductive and Maternal Health at the Institute of Tropical Medicine in Antwerp, who was the lead of the global survey that Aline has just presented. So fantastic. So I think we've done very well between us in terms of getting a range of disciplines and professions. We have midwifery and nursing, in honour of the International Year, of course. We have obstetrics, public health, maternal and newborn health and social science. We don't have the voices of women, although some of us are obviously women on this call, and I dare say we could all talk about our birthing experiences of our wives. But there is this issue about when you're talking about respectful care, really important to acknowledge that clearly our perspective as researchers and providers may well be very different from the women receiving. Unfortunately, we weren't able to invite a woman on, but we just want to acknowledge that. So how this will work, this panel conversation, is that there are 4 panel questions, and I'm going to direct those to different panel members to answer. With the time, rather strictly trying to encourage you to give your answer in as 2 minutes, as close to 2 minutes as possible. And for those who haven't seen, I have the dreaded bell, which will indicate when 2 minutes is up, just because we are really bound to keep to the timing because of the technology. So I'd just like to remind people there will be polling after we've done the panel conversation. So get familiar with with your app, and also to keep posting questions to the Q&A stream that is also on the app for the conference. So on that note, I'd like to start off with our first panel question, and not surprisingly, given those 2 excellent presentations we've just had, I'm going to ask Asma and then Lenka to basically tell us which key finding from the 2 presentations struck them the most and why. So which key finding from the 2 presentations struck you the most and why? And I'll turn to Asma first, please. Thank you.
Well, thank you very much. It's a pleasure to be with you and to participate in this panel. 2 really excellent presentations. And if we want to summarize the research findings on COVID-19 in pregnancy, I think I was maybe not surprised, but certainly the global survey and the change in obstetric services and attendance and ability to provide the care to pregnant women during the COVID pandemic. Very interesting findings, consistent with what we have noticed being clinician on the shop floor during the pandemic. Reduction in the attendance, reduction in even emergencies, use of even availability of the healthcare professionals. Certainly there was staff shortage. From the second presentation, in terms of the estimate of mortality and morbidity of pregnant women who suffered from COVID, difficult because unfortunately the research studies or the evidence that we have so far to some extent is biased, and I think Tim has demonstrated that. But certainly it seems the overall impression that the mortality during pregnancy is not necessarily different to non-pregnant women. Certainly the risk factors is also similar, so more likely in women who are obese, more likely in women from minor ethnic backgrounds or women who have medical comorbidities. I think what's interesting also to maybe highlight that was not really discussed or presented in these 2 talks is the obstetric outcomes of the pregnancies that had COVID. And this is to some extent has been consistent in the research studies of increase in preterm births, mainly births, and also increasing the rate of cesarean section. To some extent, that has been consistent in the literature and the studies from various healthcare settings. And the other thing, which is again hasn't been discussed, is increase in stillbirths, and that's been reported from UK in a number of individual hospitals, but also in globally from a number of studies in Nepal and in India.
Well done, Asma. I haven't got round to pressing my bell. Thank you very much indeed. Lots of key points there. I'm not going to discuss it now. I'll just ask Lenka to give her feedback on what the key findings were of the 2 presentations, and then we'll say a few words about the comparison. So Lenka, over to you.
Great. Thank you, Wendy. And perhaps I'll speak also from the perspective of knowing a little bit more in depth the findings that Aline so nicely presented. But to me, what I was most impressed about is actually the speed of the research that Jim presented, and about, we know about respiratory illness, and we knew what SARS and MERS had done to pregnant women. So I think these cohort studies, the speed of assessment of how to care for women that have COVID and what are the clinical outcomes was really impressive. I think the provision of care to women with COVID was a little bit lacking behind, and I think here one of the key findings is that we, especially we in high-income countries, have not really learned a lot of the lessons that can be shared from low-income settings. And here I'm talking specifically about Ebola and how, for example, issues like, oh, it takes time to put on PPE and it's hard to talk to the woman in PPE, were lessons that had been learned in Sierra Leone and Guinea and Liberia, and somehow they never managed to penetrate into the high income settings. So this was a surprise to the providers reporting from Belgium, from the UK. And the second key finding I think I derive from it, from these presentations, is that we also had to pay attention, obviously, how to provide care to all women, not just those that had been affected by COVID. And here the surprise to me was the change agents that happened. How did we manage to push back on bans of birth companions, on separation of newborns from mothers? And these were individual providers, they were individual teams, they were facilities that pushed back at policies that or guidelines that were not evidence-based, that were disrespectful. And the units of analysis that we usually work with, which are countries or counties and districts, were to some extent irrelevant. I'll stop there.
You just wanted to avoid the bell, Lenka, didn't you? So you must have heard the alarm clock going off. But thank you both very much. I mean, you've been very succinct, and there's many things there about one of the things, I guess, is that you've both been talking, possibly, we said we'd have a global scenario here, but clearly there is a distinction between what's going on in high-income countries and low-income countries in terms of the background health system. And one of the questions I'd like us to come back to is the evidence, as Jim, you presented, seems to be that maternal mortality doesn't seem to be higher. And yet the assumption is in many low-income countries that we are seeing, or we're likely to, in fact, there was a paper published in the Lancet suggesting between an 8 and a 39% increased risk of maternal mortality in low-income countries. So again, I'm not, one is right and one is wrong, but we do need to acknowledge that these different scenarios and the health system strains in low middle income countries may mean that it's translating into a mortality impact, not directly because of COVID, but because of the indirect knock-on effects. And I hope we can come back to that. But Lenka raised a very good point about not learning from previous mistakes. I have various talks that I give about do we never learn? And Ebola is an example where PPE was a major deterrent to it was needed, but of course it led to lots of fear and stigma and a lot of decline in uptake of care for really important reasons, not to do with Ebola. So very, very good points indeed. And let's park those. Everyone listening, send your questions, and the panelists as well. If you want to pose things to each other, we hope that we've got some space to do that as well. So I'm going to move on to the next panel question 2. And it relates to what we've just said, is some ways that we're hearing from many countries that the uptake of delivery care has declined. So the numbers going in parts of Nepal, for example, 50% decline presented by Ashish in his paper, fantastic paper showing a major decline across 16 hospitals. But I guess paradoxically, could that decline in numbers be leading to improvements in respectful care in some settings? So the question then is, could the decline in uptake paradoxically be leading to better quality of care, as I was saying earlier, respectful care, and why might that be? And I'm going to ask Peter, Beatrice and Jim to comment on that, and turn to Peter first of all, please.
Thank you so much. I think the answer is it depends, and in general, maybe not. It is not leading to better respectful care. I mean, if we have a context in which there is a lot of fear, a fear for COVID by both the provider, but also the client, the mother, so everything ends up being rushed. And remember now people wear masks and other gowns. So really, in terms of face contact, it's quite limited. Leading to a lot of rush and therefore not effective care. But on the other hand, when there are few mothers, perhaps they could be attended to better. But I think where they could be getting some respectful care is that people have resorted more to private facilities. And these private facilities, of course, people they have motivation to get resources, to get money, so they attend to patients better. But also, in the case of Uganda, many women are now delivering at TBS Now, TBAs are not really recommended, but in terms of being culturally relevant and providing care which suits the context, they are providing more culture relevant care. They welcome mothers. Sometimes they bathe mothers. They give them tea. They give them massages, and you could take it in a way to some extent that this is more respectful care. They also provide affordable care. So in general, I think for me, for this answer, is that the context of COVID is not necessarily providing people to be able to provide more respectful care. And some of the resources, like the gloves and other supplies, are in short supply, and perhaps they are competing for these supplies with COVID. That is what I can say in this context. So we will need to know how to provide more respectful care in the context of COVID in our settings. Thank you.
Thank you, Peter. Yes. I mean, I think it's like a lot of things. I guess it teaches us from research, and I know that some of the research that you've done is that you always have to listen out for perverse effects, or you have to look to see things are not always what you expect them to be. And it may be, just as you said, if there's less crowding, then maybe some women that are getting better care at one level. Anyway, let's move on. Let's importantly, Beatrice, who's midwife and nurse and teaches midwifery and nursing. What do you think? Do you think there's a chance that COVID could be bringing some sort of possibly more respectful care in some settings, and why might that be?
Thank you so much, Professor Wendy. Personally, I would say no. COVID-19 would not lead to more respectful care in some settings, especially in the low and middle income countries, because COVID-19 has come out. It has led to reduced from the maternity care, everything concentrated to COVID-19 crisis. And then you find more women had to delay to get appropriate care, and the women have been reluctant actually to access care services. And most of the time it means when you see a woman comes to the facilities, they are already in a critical condition. But if they are not in a critical condition, it means they will not come to the facility due to the fear that they had. And also most of the time you find that the providers are more stressed given the increased load from potential COVID-19 infections, and also due to the fact that there is inadequate maybe PPEs and also overstretched health system. You find stressed providers have shown to be more likely to abuse women, or it can also even be physically because they are already stressed. And you find that poor communication and stress are likely to lead to situations where providers perceive women as difficult, while it is not the case. And due to this fact, you find most of the, I would say, respectful maternity care rights have been violated. For example, in a by the resources are scarce, especially in the low-income countries. It means you work in an environment whereby you are really overwhelmed, and you find that there are so many deficiencies. Even if women in the facility, they will not receive the care they deserve. And that right of receiving care is being violated. But also another case, I could say there is an example whereby women and their babies have been neglected, they have been abandoned within the facilities, and they have been restricted to access care due to the fear of it. And you find due to the fear of COVID, even a baby can die. But also there have been an alteration of proven practices evidence, whereby you have to mandatory separate mother and one just because of COVID-19. And there have been some restrictions on breastfeeding. There have been prohibition companions into women within the facility. And so all these rights have been violated during this COVID-19. And then we should think of the ways on how can we really apply and give women effective care deserve COVID-19. Thank you.
Okay, thank you, Beatrice. And I know that Beatrice is joining us from Dar es Salaam, and some of that video, some of the connection is a little bit grainy, but we heard you very well. So I think your overall conclusion, Beatrice, is that you don't think there's any likelihood that there is a perverse positive effect on respectful care, that by and large it's negative, and you would expect respectful care to decline. So thank you. Last but not least, in this round of questions, let's ask Jim, your view. Do you think there could be a paradox here with respectful care possibly increasing in the context of COVID-19?
Thank you, Wendy. I do, actually. I don't have any recent experience of working in low and middle income countries, but so I can only really talk about our experience in Nottingham, where it's only fair to say we weren't very severely affected by the first wave. But during the first wave, we found fewer patients coming up for antenatal visits and scans and sort of antenatal baby care visits, and the hospital was quite remarkably quieter. And although I agree that probably some people missed important visits, I think quite a lot of people missed unnecessary visits. Certainly in obstetrics, I think we do quite a lot of unnecessary interventions on low-risk women. And I'm going to chuck in 3 slightly controversial ones. We encourage people to worry an awful lot about altered fetal movements in the UK, and I don't think the evidence supports that very strongly, and it leads to lots of people coming to the hospital and sometimes harmful inductions. And during the first wave, that pretty much stopped. We do an awful lot of ultrasound scans on low-risk women. Now, I'm quite clear that ultrasound scans are effective and helpful for high-risk women, but for low-risk women, I think, again, there's a possibility of that doing harm. And during the first wave, quite a lot of people avoided that potentially harmful thing. And then the one I feel most strongly about is that the evidence has for a long time said that for low-risk multiparous women, certainly in the UK and in Holland, and there must be other countries that are similar in the world, it's safer to have your baby at home. And very few people do, but the evidence is really very good. And COVID has added to that evidence and gives us a real opportunity to encourage those women to avoid the risks of infection in the hospital and have their babies at home. It's not easy. I've got a daughter who's pregnant now and due in January, and a niece also pregnant now and due in January. Both second babies, normal deliveries last time. And I've been saying to them, come on, have it at home. You don't want to come into this terrible hospital with all these viruses flying around. And I think paradoxically, COVID might lead to them getting a nice home birth with more respectful care.
That's very interesting. We could devote the whole of the rest of the panel to home births. But Asma, yes, do say.
Can I say something that I don't necessarily agree with you, because certainly where I work at St. George's, and we had certainly more cases of pregnant women affected with COVID during the pandemic. The hospital was really busy with COVID patients with COVID. Unfortunately, we had observed a number of pregnancies that with antenatal births. Unfortunately, the common theme was delayed presentation of reduced fetal movements, of women saying, well, yes, the baby, but I was afraid of coming to the hospital. So she delayed it for a day or two. I entirely agree with the evidence of the AFFIRM trial that reduced fetal movements, that the intervention not necessarily reduces the birth, does not necessarily mean that we just ignore women's concern about fetal movements.
Absolutely. I mean, I think it goes back to what we were saying earlier about this issue of what we might feel as providers or indeed researchers may be very different from women on the receiving end of feeling. Not to say our views aren't valid, but I think, I mean, the reason for this question was there is some mounting evidence coming from a number of different places about some potential benefits in inverted commas, of course, they have to be balanced against the sort of negative effects that Peter and Beatrice have particularly mentioned. But things like less crowding, this issue, I'm not so sure about going to a private facility, maybe be something that's necessarily beneficial if you can afford it, because that's the other challenge that we've got, is with a lot of people's livelihoods affected by the COVID-19 pandemic, which means their affordability to seek care is also impacted upon. So there's a lots of checks and balances, but I think it just reminds us as researchers is we assume things move in a particular direction. My sense is in something like this, a very sudden onslaught or insult to a health system, is we've really look carefully. If it's a system, then things move around and one benefit may be one loss somewhere else. And we need to look at how and who is adversely affected versus who is potentially positively affected. Like, for example, TBAs, if they have more opportunity to deliver women, if they are connected up with the health system. Jim.
I'm going to endorse that very strongly. If you're a health manager and you're organizing a health service, they always say, never let a good crisis go to waste. And yes. COVID has opportunities for changing practice in substantial ways. And it's sometimes, some changes will be doing things differently. Some changes will be stopping doing stuff. It'll apply differently in different countries, but it's important to think about this. It's not just a disaster, there are opportunities.
And I absolutely, Jim, I think that's really important. I mean, there are many examples where we have to use this as a lever to say, for example, water essential for hand hygiene. Why have we still got 25% of health facilities in low-income countries without water? So we just need to remind ourselves there are some basics that COVID-19 is going to shine a light on, and we need to rally around showing how this can't continue. We can't have healthcare workers told to practice hand hygiene without water, soap, or certainly not alcohol-based hand rub. So yes, I like that. Never let a good crisis go to waste. So let's move on to the third question. And this is a question about trust. And it's, how can the essential trust between women and care providers be restored, given the barriers of physical distance, face coverings, remote consultations that have been introduced by the response to COVID-19? So how can we rebuild this essential trust between women and care providers? And I'd like to Jim, would you like to continue and give us your response, and then Beatrice and Peter?
How can we build on trust? I wasn't expecting that question for me. One of the things I've noticed, I'm just going to waffle on for a little bit now. One of the things I've noticed is that practice has changed quite a bit since I'm always wearing a mask. And most of the patients I see are also wearing masks, and I find it quite difficult to sort of introduce myself in the normal way and to reassure women who exactly I am. And I usually end up standing at the end of the room and taking my mask off and having a special sort of hello at the very beginning of a consultation. And of course, the other thing I have is that I'm rather deaf. And so I find it very difficult to hear what people are saying when they're wearing a mask. And I've taken to using my phone, and there's a very nice Google app on the phone where, as you speak, your words come straight out onto the phone, and that sometimes helps.
Right.
But otherwise, I don't have any great tricks.
I should apologise for that. I have to say, as the chair of the panel, I have a combination of technologies, including looking at my phone, looking at the screen, trying to press the buttons, and I have button confusion. So that question wasn't come to you, but you answered it beautifully anyway. So
I waffled through.
So I do apologise. Goodness me, all the technology here, and I get the order of the questions wrong. I do apologise. So, but you answered very well. But the question was about how can we build the trust? And I'd like to pose that to Beatrice and Lenka. Beatrice, would you like to?
Thank you again,
how can we build that trust?
One of the means which we can use to increase trust is first to be able to educate well the women, individualize the counseling and advice regarding self-care as a pregnant woman or postnatal woman, and also to give a message about COVID-19, what it is, how is it prevented, how it's meted, so that women can know. And if she's maybe breastfeeding, can she breastfeed or not if she's either infected with 19? So we have to give women a clear information about COVID-19 itself, about corona infection, and what to do if a woman is infected during pregnancy, labor, or postnatal period. But also, I think maybe nurses and midwives need to offer psychological support, reduce fear among women who seek care in their facilities, because women developed fear they were not accessing the health facilities. But I would give an example in Tanzania now. It's like we have already overcame the fear, and we're attending the facilities as it used to be before, and they get it, and all those measures of prevention of COVID-19 are adhered within the facilities. And last but not least, maybe we should be able to provide women-centered care that ensure dignified and respectful care to create a positive birth experience. And in that way, we will increase trust, and other women who hear that positive birth experience, they would actually access the services. Thank you.
Thank you very much, Beatrice. So it's very much a two-way rebuilding of trust. It's women's trust in care providers and care providers' trust in women. I know I've certainly heard some care providers being concerned about whether women really are practicing good hygiene at home when they're coming in. Obviously, some of the circumstances make that very difficult, but trust is always a two-way process. So thank you very much indeed for that feedback, Beatrice. Lenka, what do you think from your survey or your experience? How do you think this essential trust as a core component of respectful care could be rebuilt?
Yes. Thank you, Wendy. And when I saw the question that you sent through earlier, my first reaction was the trust actually broken in the first place? Because what we are seeing and hearing from providers is they are actually, from individual health providers, midwives, nurses, obstetricians, is they're really trying very hard to continue providing respectful care. And so, for example, when an order came from a hospital in Belgium that birth companions were not allowed, or visitors on the postnatal ward were not allowed, some of the midwives were trying to sneak the husbands in through their kitchen, through the staff kitchen, to see the woman and the baby for a couple of minutes, even though this wasn't allowed. So I think from the women's perspective, from the individual health providers, you can see this, you can feel it, and perhaps that trust hadn't really been broken if it was there to start with, of course. But what I think had been broken to some extent and needs restoring is the trust of women and their families and the communities in the healthcare settings or in the health facilities. And I think this is what we are seeing when women are not coming to health facilities. But let's look at it in a little bit more granular way. Women might still be coming to health centers, but they might not be necessarily going to hospitals. And this is because the bigger the hospital, the bigger the facility, the bigger the perception of risk, which is of course not unfounded. And the actual risk, if we're looking at it, is the highest risk is that the health providers infect each other and then end up infecting the woman. So this isn't unfounded. But I think, for example, we need to examine, in terms of this trust to healthcare settings, we need to have a hard look at whether we want to be putting COVID wards or COVID treatment blocks in healthcare settings where women are coming to have babies or have antenatal care. Those are not really patients. They are healthy women for the majority. And do we want to break the trust in that this is a good place to come by putting a ward with COVID patients in the same campus, for example? And I think I just want to finish before your bell rings, coming back to the providing trustful and respectful care in home settings. I am all for being very open-minded about home births, but the first thing we saw in our high-income settings is that the healthcare professionals, the nurses, the midwives, the home visitors who are supposed to visit women postnatally at home were not provided, even with face masks, were not considered front healthcare workers. And so, it's one thing to say, let's get more women to stay at home and receive care there. And another thing is to set up a system that makes it work in a respectful way, both for the women and for the healthcare providers.
Thank you very much indeed. Yeah, absolutely. I mean, this issue about trust, I mean, trust in the system and confidence in the system is really, really key. So I like the fact that you've brought it back to a sort of systems perspective, because rather than it boiling down to sort of blame issues. But I think also your comment about design, it's amazing how, that's not our own sort of specialist area. But there are many things that are emerging now about design of facilities or even design of labour wards that show that infection prevention can be improved, or indeed, as you're saying, not co-locating a COVID unit near a maternity unit. So, of course, in many situations, things are very, very difficult, particularly in... So, Peter, do you think that might be possible, Peter? Do you think it's possible in the sort of Mulago, for example, that obviously was in receiving a lot of cases? Was the maternity hospital possible to be, regarded, were COVID cases, do you know if COVID cases were going to Mulago or where the maternity patients are going as well, or were they sent somewhere separately? And I'm sure someone's going to answer their own experience.
So in Kampala, the hospitals had already been separated. So women go to a couple of hospitals like Kawempe, which is basically now a hospital for women and children. So that way, then the COVID cases are admitted in the old Mulago Hospital, or some people call New Mulago, because it had just been renovated. And then the Women's Hospital. And then in other hospitals, like in Entebbe, they were able to separate, to create different divisions, where one separate block is given to COVID, and then the rest for the other services. But then the reality is, in terms of communication, people don't know this. So the moment they know that people with COVID are being admitted to this hospital, they assume that the entire hospital has COVID cases. And that is always, there's always a challenge with communication between hospitals and also the public. And as a result, hospitals actually became empty because everybody was assuming that there are COVID cases in the hospital. But on the other hand, also people assume that even people coming for a normal birth may actually themselves be potentially COVID cases. So I think that is what has caused all this complexity, leading to almost empty hospitals. But then one of the things we've seen in Uganda, and good enough, I've been actually tracking the continuity of services for maternal, newborn, and child health. In terms of the severe cases, they continue coming to the hospitals, but coming quite late. And when they come late, even if the actual numbers have reduced, because they are severe cases, they require more health workers, but also they require more resources. So in essence, providing respectful care is still a challenge in this context.
Thank you very much, Peter. You're right. I mean, again, it's this issue about you do something to sort of improve the situation, and for it's isolating the COVID cases, for example, and then it creates fear in a different group. So I think that again, it's this system perspective, and you with your background know a lot about looking at the whole thing and not just picking out small parts, because we're pushing problems from one to the other. Okay, moving on to the final question to the panel, and this is a question about research. And I'd just like to, the question is, so what do you think is a priority research question for understanding MNH care in the context of COVID-19? So there have been many lists of priorities, but this is a chance to give you your personal perspective. And what do you think is missing in our understanding of MNH care in the context of, as we face this COVID-19 pandemic? And this is going to Asma, Peter, and Jim. So Asma, would you like to tell us what you think is a priority question? And you obviously won this wonderful BMJ paper that's just come out, some interesting findings on the living systematic review.
Thank you. I mean, I think one important question I believe is that how to tease out which adverse pregnancy outcomes which have been reported are related to the infection itself, the virus, and which ones are related to the change, the massive change in obstetric services that occur during the COVID pandemic. So if we have, let's say, increase in stillbirths, which has been reported, consistently, and there are studies from Nepal and from India, we have reported increase in stillbirths. Is it because of the virus? Have these women had COVID-19? Or actually, is it because of the massive change in the service and the care that these women received that have led to increased stillbirths? And whether we can actually correlate and tease out which ones was related to COVID, which ones is related to the change in the care and the service that we provide, so that we can learn the lessons for the next pandemic and be prepared that whatever public health messages or change in the care that we provide or advise these women does not translate into adverse pregnancy outcomes.
No, very, very, very important. I mean, defining direct and indirect effects, of course, is difficult, and we notice that in HIV and maternal health as well. And sometimes the consequent impact on the service, and as opposed to women living with HIV/AIDS. So disentangling is difficult, but we do need to understand more about these knock-on effects for future and for strengthening the system. Peter, what would you say? I'm sure you have a list as long as your arm of research questions in this area. What would you say?
I actually first build on what Asma just said. In Uganda, we've seen about a 15-16 increase in the low birth weight, and from the data. But I'm asking this: is this prematurity? And if so, then what are the mechanisms that are leading to these mothers having low birth weight? And a follow-up on that, then what are the short, mid-term, and long-term effects of COVID-19 on those who are either directly affected or indirectly affected? But perhaps the main research question I would ask is, what kind of models of care work to improve continuity of services in different contexts during this COVID pandemic? Because we are having all this distortion of services, and we need to develop models, but different models might work in different contexts, even within the same country. Like what model works in a rural setting, what kind of model works in an urban setting, and does this assure continuity of services and respectful care, and is it affordable? I think those would be my primary research questions.
Yes, you're quite right. I mean, this issue, I mean, we all know that sometimes systems move very, very slowly. And so when you have an insult like this, it becomes more like a humanitarian situation, a very big insult that happens suddenly. Maybe we can learn something by looking at those in those contexts where suddenly services have had to change for all sorts of, as I said, it could be an environmental disaster, or it could be a conflict related. Maybe we should learn, because I think certainly in some parts of the world, that ability to mount a response may be good for a specific infection, for example, a cholera outbreak, but not necessarily for the system to respond. So maybe we should have a look. Maybe we could learn some lessons from humanitarian situations. I don't know if there's anybody listening in that has experience, but to me, I think it's the issue about what can we do rapidly, what can we redesign in the immediate term, you know, this issue about triaging, what can we do to recognise the fear that's going to be in the community. I'm not so sure I'd suggest we turn to look at the UK's response, but that's another whole panel that we could have on that. Asma, did you want to respond to that before I ask Jim? Yes.
Yes, I mean, in terms of like the changes, and something that I think is being witnessed or observed by many people is a rapid implementation of virtual care and the use of the technology, which would have been normally taking so long to implement. And because we've been forced with this massive changes, and the fact that the rapid uptake and you know, the people becoming very familiar to use technology and virtual care and telephone consultation and home blood pressure monitoring during pregnancy is something that probably, you know, potentially some of it would continue. The COVID legacy, or what Tim was saying earlier, is that maybe there are certain things that we can learn from a good crisis.
Right. Thank you very much indeed. Yes, I mean, again, it's this issue about making good out of a crisis, as Jim was saying, and how it's forced us to grapple with certain things. So, Jim, priority research question.
Okay. I've got two things that I'd like to talk about. They haven't been raised in this session so far. First of all, the world is doing a lot of research on COVID, and I think it's quite impressive, actually, the way the randomized trials and things are being done. And we're learning about the effectiveness of dexamethasone and things like that, and the ineffectiveness of chloroquine. But it is very disappointing that pregnant women are not participating in those trials. And it's not their fault. They're mostly not even being invited to participate. It's the researchers' fault and the clinicians' fault that we're actually sort of rather excluding pregnant women from research into COVID.
Yeah.
And I would like to sort of emphasize how important, if any of us or any of us who are listening have an opportunity to recruit pregnant women to trials, good quality trials, like in the UK, the recovery trial, we should take that opportunity. It will be good for pregnant women if they participate in research, and we will get research that works for pregnancy. And then the other thing I wanted to talk about is the evidence about just the care of pregnant women with COVID. It has been very disappointing, and there are still many centres who are doing caesarean sections with COVID as the indication, and that is not, the evidence does not support that. Obviously, if a caesarean is being done for some other reason, that's fine, but just for COVID, it's important to emphasize the evidence doesn't support it. There are still many centres advising women not to breastfeed, and the evidence absolutely does not support that. Breastfeeding doesn't increase the risk of infecting the baby, and in fact, it probably reduces it because of the antibodies in the breast milk. And thirdly, there's still centres practicing isolation of babies, separating them from their mothers. And again, it's important to, the data are not very good quality, but such as they are, they don't support that policy. So I would ask for more higher quality research, hopefully to show that those three interventions are harmful and stop people doing them. Thank you.
Very, very helpful indeed. And there was a similar plea from, I think, Marian Knight about the inclusion of pregnant women in trials that came out much earlier as well. And I don't think you're quite right, there hasn't been a response. Asma, just one quick point, because we're now going to move on to the polling. Did you want to say something? And I'm going to just check on.
In response to Tim, so the recovery trial has actually included pregnant women. The numbers were very, very small, so it's difficult to draw a conclusion or apply the findings to pregnant women. The second point about the vaccine trials, I'm a member of the COVAX group, which is supported by the Bill Gates Foundation, which essentially look at vaccine or the feasibility of vaccine trials in pregnant women. And hopefully that would come up with some key recommendations or take into account all the safety aspects and what evidence we need to see before we can recommend or license vaccines in pregnant women. But it's not as simple, because safety, you have to have certain safety metrics first before actually we can offer the vaccines to pregnant women. So, but yes, I concur with your recommendation, of course.
Thank you, Asma. Let me just
absolutely on the side of the angels. Well done. Recovery plus.
Because research is so key to all of us. Peter, do you want to say anything more about any response to what's just been said, or Beatrice, anything else you'd like to add, or Lenka? Because we're going to go to the polling now.
Maybe Peter here. I actually about 2 months ago, one obstetrician called me and asked me, Peter, is anybody doing research on pregnant women who have COVID? And I said, well, I don't have the money, but let me go and find out. So I went to my chair of research and asked, has anybody registered a study to do research among pregnant women? And he said, no, I'm not aware. And I called back to say, no, we don't have anybody doing it. I said, this is very frustrating that we will not learn anything. And the thing I thought about was, which I discussed, well, why can't even our government finance research among its own population? Do we need to look to the UK or the US to really learn from our own context? So this kind of research is very important. But then how can resources be mobilized quickly and by whom? Those are some of the issues that we are struggling with as scientists. As we would like to do more research, we don't have the resources.
Absolutely. Well, I know that I think we do have listening on the to the GLOW conference a few funders. They tend not to declare themselves for obvious reasons, but I'm sure they're busily writing down research questions that you've just posed and those challenges to doing it. So Beatrice or Lenka, would you like to add anything before we move to the polling? Lenka?
I can, yes, just to touch on the point that you mentioned, Wendy, about learning from previous disruptions and emergencies. We are actually working with Annie Portela, you'll remember her from yesterday, on a scoping review of the literature to learn these lessons from earthquakes and hurricanes and other disruptions. But what strikes me, a general sort of research priority point, what strikes me is how little actually is documented in what we traditionally go to, that peer-reviewed literature or even commentaries. And I think what really comes to the fore to me is that the innovations, the solutions, the adaptations that people are discovering as individual providers, as teams, as healthcare facilities are going to get lost also from COVID unless we put a concerted effort to document them. And they don't have to all be review papers. They don't even all have to be evaluated formally, but they need to be documented somewhere because they can help us not just for this emergency or future pandemics and emergencies, but they can help us solve issues that have long been outstanding in maternal and newborn health, like referrals and transport, etc.
Yeah, and triage. Thank you very much, Lenka. So a call for someone to create a repository of experiences, which would be really helpful. Beatrice, was there a particular research question from your nursing and midwifery experience that you feel you'd like to flag?
Yeah, maybe I think we need to do is regarding this issue of trust. As midwife and as a large number of healthcare providers are midwives, how do we help women to overcome, physiologically, these states of crisis? Because they have been through a lot of stress. You find someone is maybe supposed to even to go to the hospital. So how do we help women so that they can overcome when the crisis of this infectious disease? But another thing, we should look at the effects that have been brought by COVID-19 and how can we keep on strengthening our health system so that all those bottlenecks that have been existing already, because COVID-19 have complicated them even more. And then how can we learn out of this and try to improve the health system so that they can accommodate even these crises that are happening? Because we have had some crises like Ebola in some of the countries already, and we should let some more be done on the effects of COVID-19 on the health system and how can it be improved so that we can be able to care people when these crisis pandemic diseases happens. Thank you. Over to you, Professor Wendy.
Okay. Unfortunately, the technical side, we've lost Wendy due to the Wi-Fi or the connection. So, but that was an absolutely fantastic session, wasn't it, Helen?
It was brilliant, yes, thank you.
And so many really thought-provoking comments that have come through that are all on the Q&A section. And I know Wendy will be really keen to answer these, so keep them coming. And hopefully after this session, she'll be able to answer some of those for you as well.
So we're just going to have a very short break, and at 3:10 we're going to come back to you with two parallel sessions. So you've got a choice to make as to which session you'd like to join. Tista's going to be with a panel of oral presentations, continuing our theme of respectful care in the year of the nurse and midwife. And I'm going to be with a panel discussing research challenges, so the real world challenges that researchers come across, and looking at it in a very sort of 3-step way from program management and finances and ethics. So that'll be very exciting. So look forward to joining you again after the break.
Thank you. And thank you also to all the panel members that have been part of that fantastic presentation for their time and contribution today. So thank you, all of you. You've been brilliant.
Thank you very much.
Thank you for your time.